ladies and gentlemen. I hope everybody's had a chance to finish their lunch. And I understand that lunch this time was much better than last year. And now I understand why Dr. Banerjee was so focused on the menu. He says he cooked it. He's very talented, but somehow I doubt that. Next, I want to introduce our next speaker, who is Dr. Bruce Bowers from Medical City. He's the director of both the invasive and the non-invasive labs at that very large hospital in North Dallas. And in addition to being the director of those departments, those labs, Bruce has been instrumental in mentoring the Dallas VA Hospital in our new TAVR program. And for this, we are very appreciative. Also, we are not only appreciative, but very fortunate because in the country today, there are very few individuals who have more experience than Dr. Bowers with TAVR. So I am very pleased to introduce him, and I know we will learn a lot of good stuff from you, Bruce. So please come on up.
Okay, great. Well, good afternoon. It can only go downhill from there, from that introduction. So I don't think I could possibly live up to any of that. But it is a pleasure to be here with you. I've been working with the good team from the VA now for almost a year, trying to come from concept to inception to actually doing transcatheter valve implants at the Dallas VA. And I'm proud to say that, I guess, what was it, the 30th, Subhash? Was it the December 30th? The Dallas VA had their first successful transfemoral transcatheter aortic valve replacement for a veteran here from the area. So they deserve a round of applause for that, because that's not easy to do in the as many things can be challenging in the VA system. This one serves to be particularly difficult. So with that said, some disclosures here. Jerry touched upon the fact that I work primarily at Medical City. I also do work at the Baylor Heart Hospital up in Plano as well. So looking at TAVR, we're about to meet the 12-year anniversary of the first transcatheter valve implantation that was done by Alain Cribier in Paris. And that was done on April 16th, 2002. And one thing that, I don't know, maybe they do this at the Dallas VA, but after Alain put in his transcatheter valve, they decided that they'd celebrate with champagne. So Subhash has told me that if I come and do cases there, that this is the way we'll celebrate. So I'm all in. But that being said, this was sort of the feasibility, the first in man, and that is the first patient who was suffering with critical aortic stenosis and cardiogenic shock that was treated successfully with the transcatheter valve and published in Circ. Interestingly enough, it was 12 years before that implantation that Cribier actually started making sketches of what this valve could look like. And I think the incredible part is that what was in his mind's eye and what actually came to fruition and how this procedure is actually performed today, some 22 years and 24 years later actually, is pretty much where we've come from first generation to second generation to the Cribier Edwards device that was released, and we've been performing implants with that device since 2006. And at that time, there were two sizes of that valve, 23 and 26, and that is a bovine pericardial tissue valve. So what have we learned since 2002 on this odyssey of transcatheter valve implant? Right now in the United States, and I'm only going to stick to U.S. Known data, and I won't go into European registries or data, but we have the partner trials 1 and 2, and then we also have the CoreValve extreme risk evaluation. Looking at the partner 1 trial, this was a landmark trial, 2 parallel trials going on that were individually powered. We had a cohort A, which was high risk. We had a cohort B, which was inoperable. We had over 1,000 patients that were enrolled in the trial. The high-risk group was randomized to transfemoral versus conventional aortic valve surgery, and or if they did not have adequate iliofemoral access, those patients were then placed into a high-risk transapical arm of the trial. The inoperable group, or cohort B as they've become known, was only randomized against medical therapy. I can tell you medical therapy for critical aortic stenosis is a bit of a joke, but most of those patients did end up getting balloon valvuloplasty. So in October of 2010, the results of cohort B were released in the New England Journal. 8 months later, the high risk or cohort A results were presented again in New England Journal. This is what cohort B, that inoperable group that was going up against medical therapy, this is what it looked like in terms of the results. You can see all-cause mortality at 12 months reduced by 20%, and following it out to 3 years, it's over 26%. So that basically puts the nail in the coffin that we're not ever going to see another trial that is going to randomize against standard therapy for transcatheter aortic valve replacement. That's done. That argument's over, and you'll never see that again. Then we moved on to what did transcatheter valve replacement look like compared to conventional aortic valve replacement, and you can see that it was non-inferior, equally efficacious results, and that extends out to 3 years. And so here we have non-inferiority that's been proven in the Partner 1 trial, okay? So what did Medtronic do with their CoreValve platform? Well, right now, the data that we have is from their extreme risk group. That STS risk, by the way, in Partner 1 was 11. The Society of Thoracic Surgery risk score, that means an 11% mortality rate at 30 days with conventional surgery is what was predicted. In the CoreValve trial, the STS risk was 10.3, so very similar. The CoreValve platform is a self-expanding platform, not a balloon expandable platform. And what we've seen is, and this was just released at TCT in the fall, is that CoreValve also, from an all-cause mortality and major stroke incidence standpoint, set a bar of performance that if the valve performed better than this 43% mark, it had met its endpoint, and it did that in a highly statistically significant fashion. And so we now have 2 platforms. CoreValve, from that data that I just showed you, got FDA approval literally yesterday. Okay, so now there are 2 commercially available products on the market. One is the Edwards Sapien platform for high-risk inoperables, and then now we also have the CoreValve platform for the extreme risk or inoperable cohort from their trial. But what did we learn from Partner 1? We had some concerns. The concerns were the following. We had strokes, we had vascular complications, and we had paravalvular regurgitation. Looking at the stroke rates, this is cohort A, so these were patients that were being randomized, again, against conventional surgery. If you break this out and you really look up front in the peri-procedural period, particularly in the first 72 to 96 hours after implant, there's a significant separation in stroke rates for the transcatheter group versus the conventional surgery group. Then we move on and we look at 12 months. TAVR has a 6% stroke rate versus 3.2 for conventional surgery. And if you follow it out, interestingly enough, though, out to 36 months, they basically become even, okay? So up front, there's a cost to be paid, it looks like, with transcatheter valve therapy as far as the stroke risk is concerned. What about major vascular complications and transcatheter valve implantation? If you had a major vascular complication with the transfemoral valve implant, it was an independent risk factor that you were going to be at higher risk for death, okay? So not to be taken lightly. What about the paravalvular regurgitation? And this shows you how great the surgeons are in this country about putting in their valves. And just looking at the numbers here, over 50% of the transcatheter valve patients in cohort A of the PARTNER trial had either mild, moderate, or severe paravalvular leak at the end of their implantation at 30 days. And you can see there was only a very small percentage of patients that had any paravalvular leak in the conventional surgery arm, and most of those patients either had none or a trace degree of paravalvular leak after conventional surgery. What did it mean and how did it impact patients? Well, what we found out was that if you have more than mild paravalvular leak, you're at high risk for mortality. Again, it's an independent risk factor, just like vascular complications, for having an increased risk of mortality. So mild, moderate, or severe, it did not matter. In PARTNER, you were at higher risk than patients that did not have that. Not to belabor this, because this starts to get a little bit into the granular aspects of what we do as implanters, but one of the problems is that you have to choose the right valve size for the patient. Sounds easy, that should be a sort of a no-brainer kind of concept. The problem is that if you look at PARTNER 1, the way that we were doing that and the way we were trying to figure out what valve size to put in these patients, we were primarily using esophageal echocardiography. And here's a patient that has, on the top panels, the top 3 panels of this slide, show that there are 3 different measurements. This is all in the same patient. It measures 21.6, it measures 25.9, and it measures 28.1. Well, what size valve do you put in that patient? A 23, a 26, a 29? So if you look at the bottom right panel, this is what it looks like with CAT scan and with a CTA. And what we see now, this is in retrospect, by the way. We didn't know this when we did it. But now the area is 797. That's larger than we would even use for a 29 millimeter valve, okay? But we put a 26 millimeter valve in the patient, and we were left with a significant amount of paravalvular leak because we had misjudged the size of the annulus. And this is what it looks like when you explant that and you're looking up from the LV outflow tract. You can see that the valve is not conforming to the aortoannular complex, and you have a significant amount of paravalvular space and leak that is there. We've now gone into the iterations of how do you actually quantify this. If you ask the echosonographer, they're the experts at it, and it really should be the gold standard, because what the interventionalist has been using for aortic regurgitation quantification has been an aortic root shot. And so I'll say at the end of the case, well, it doesn't look bad to me. It looks like it's 1+. And then, they do a deep transgastric view, and then all of a sudden, I'm getting measurements from them that are more consistent with moderate or severe. So now we have a way to quantify it. That being said, if you look at CoreValve and you look at the paravalvular regurgitation with their system, it performed better than the Edwards Sapien platform did. You did not see the same amount of moderate or severe. And the other thing I'll draw your attention to is look how the improvement in paravalvular regurgitation continued as the time went by. So there's something about that valve and that nitinol platform that is probably allowing it to conform better over time to the aortoannular complex, and probably reducing the amount of paravalvular regurgitation that we have. The other thing about that is that their paravalvular regurgitation behaved differently in terms of mortality risk for their patients versus the Edwards patients. And here you can see that regardless if you had no to trivial to mild to moderate, even moderate degree of paravalvular regurgitation with the CoreValve did not portend a bad outcome. Only those patients that were left with severe paravalvular leak had an increased risk of mortality compared to the others. What else did we find out from CoreValve? We found out that the major stroke rate at 1 year was 6.7%. At 1 month, it was 3.9%. A little bit better than what we had seen with Sapien. The other thing was that the vascular complications that I have highlighted in green were less than we saw in Sapien. And then the one, maybe Achilles heel that we have for the CoreValve platform is that there was a much higher incidence of permanent pacemaker implantation in that trial than what we had ever seen with Sapien. Sapien, it runs about 4%, and we were looking at almost a 25% rate of permanent pacemaker after a CoreValve implant. So now we need a second generation technology to address these issues. And that's what Partner 2 looked at. Right now, all that we have available to us in terms of data for Partner 2 is the inoperable cohort. I will draw your attention to a couple things about Partner 2. There were 6 nested registries that are listed there. Small vessel meant that the iliofemoral minimal diameter could be 5.5 millimeters. The other thing was a transapical group of patients, a valve-in-valve group of patients, and then we started looking at larger valve sizes like a 29 millimeter transfemoral and transapical implant. Data was generated from 28 sites across the United States. Medical City was one of those. And this is a head-to-head sort of comparison between looking at the Sapien first generation technology to what we have with XT. XT is a cobalt chromium platform. Again, it's bovine pericardial tissue. But the delivery system that you can see down here, down here on the bottom is, what did I do? Let's see here. That we see down on the bottom is the NovaFlex system versus the Retroflex system. It makes a difference, and it makes a difference because when you look at the sheath size that's required to implant an XT valve versus a Sapien first generation valve, you're looking at with the XT valve for a 23 millimeter implant, it's an 18 French sheath. For the 26 millimeter platform, it's 19 French. And you can see there that the outer diameter of the sheath for the Sapien 23 millimeter prosthesis was actually 25 French. And the outer diameter for the Sapien 26 platform was 28 French. So you were talking very large devices. The other thing is that it introduced also in the Partner 2 trial was the first time that we had used expandable sheath technology. And expandable sheaths are pretty great because what it allows you to do is that the vessel only has to dilate for a short period of time as the valve prosthesis marches through. And then once it's through that area, it collapses back down. So the vessel's not being continually stretched the entire time that the valve delivery system is in there. The other part about this is how did they get the delivery system a lower profile? One thing that I will tell you, it's a little unnerving the first time you do it, but the valve is actually not implanted, is not attached to the delivery balloon when you put it into the patient. And so that valve is then mounted onto the delivery balloon in the descending aorta, okay? So you have the balloon and then the valve sits behind it and you mount that in the patient, but it does allow for a smaller delivery size. So when you compare the two, you compare first generation versus second generation technology, no difference in mortality, no difference in stroke. The one thing I will tell you about the stroke rate is it was much less than what we had seen in Partner 1, and that was even with the Sapien valve that was being implanted in Partner 1. We had a much lower incidence of stroke at 30 days than what we had in Partner 1. So why was that? Well, it was probably because there was some procedural improvement. There was probably better patient selection and patient screening, which had a significant impact on the stroke rate. But there's no difference in stroke between second generation and first generation Sapien technology. The other thing is that when you look at all-cause mortality, disabling stroke, rehospitalizations, again, the same. Did anything improve? The only things that improve were basically soft endpoints. Anesthesia time, we had less need to put in a second valve when we used the XT platform. We had fewer aborted procedures, and we didn't have as much need for cardiopulmonary support in terms of putting in a balloon pump. But again, no difference, and no difference in the big things that we look at. What did improve? Vascular complications did go down. Perforation rates, when you looked at Sapien versus Sapien XT, significantly different, and that was largely because of lower profile, expandable sheath, and again, I think better patient selection. Did the valves behave the same from a hemodynamic standpoint? Both exactly the same, no significant difference. And what about paravalvular regurgitation with the XT platform? It was actually worse at 30 days than the original platform. And it improved over time, a little bit related to the cobalt chromium platform, that at 1 year they were basically the same, but we're still, again, leaving patients with mild, moderate, or severe greater than 50% of the time, which is not a great event. So what we got was decreased anesthesia, less vascular complications, less multiple valve implants, less aborted procedures, and no need for intra-aortic balloon pump. These things didn't change. And these are the things that we're really concerned about, I think, as clinicians, as we're evaluating these new technologies. So what do we need? We need lower profile systems. We need retrievable and repositional platforms. We need to reduce the paravalvular leak. We need to be able to deliver it through alternative access, direct aortic, transapical, subclavian. We need to reduce pacemaker implantation rates, and perhaps these systems should be integrated with embolic protection systems. I would also encourage most of you that are interested in this space that you need to keep your surgeon engaged in this process, okay? The surgeon is truly the expert when it comes to the aortic root and the aortic valve. These are some new technologies that are being evaluated to hopefully address some of those concerns. One of them is the Lotus valve, repositionable, recapturable. The third panel here shows you can actually let the valve function before you fully release it. And direct flow, a novel concept, but two cuffs, one on the aortic side, one on the LV side, to hopefully reduce paravalvular leak. I appreciate your time and attention. Thank you.